So, good evening. So, today's presentation is going to be on some of the pitfalls in the management of polytrauma patients, and this has become particularly relevant in the last few weeks when a lot of mass casualty management meetings and courses have been going on. So, it's a good idea to perhaps go through some of the pitfalls of managing severe trauma patients. So, the basic approach to any severe polytrauma is you have to understand, first of all, what a dangerous mechanism of injury is. So, because that is how you plan everything else with regards to the management of the patient. Then you have to know how to do a proper primary survey and a secondary survey exam. So, trauma is pretty simple compared to medical emergencies. Medical emergencies can sometimes be anything and can be some kind of complex diagnostic approaches required quite often. Trauma, you basically need a systematic approach. With the systematic approach, you are unlikely to miss any severe injuries. So as long as you know the systematic approach well and you know the pitfalls well, then you will be able to save most of the patients you have. So coming to dangerous mechanisms of injury as per ATLS, so there are going to be some controversies here, but I just wanted to give people an idea about what a dangerous mechanism is. So fall from heights, you have a fall from height of more than 20 feet in an adult or more than 10 feet in a child. And in a child, it's also dangerous if a child falls more than three times the height of the child. So if that happens, that is considered a dangerous mechanism. But does it mean that 15 height fall is not dangerous? Not really. So there are some problems with these kind of definitions. So a high speed motor vehicle collision they have defined as more than 32 kilometers per hour, which is again kind of on the lower side, to be honest. But it depends on what exactly that particular motor vehicle crash was. There are certain crashes where even 32 kilometers per hour can be quite dangerous. MVC with any ejection of the passenger from the vehicle, rollover of the vehicle, co-passenger death, somebody in the same vehicle died, or intrusion of the the side of the roof of the vehicle, and they define it as more than 12 inches on the occupant side or more than 18 inches on any other side. So these are some of the things that they say. And pedestrian or a bicycle rider hit by a motor vehicle at high speed, that is also dangerous mechanism. So some of these are useful to know. Some of these are not going to be particularly useful, especially in India. So we are probably not going to be having much of an idea about what the intrusion of the wall and etc. is going to be for most patients. So we have to remember that ATL is basically designed in a region where the pre-hospital care is very advanced. And unfortunately, we don't work in that kind of setup in India. So a lot of these kind of details are not going to be available to us most of the time. Blast injuries, they're always going to be considered dangerous until proven otherwise, because you have all kinds of injuries which are possible. Penetrating injuries, especially to the torso, anywhere to the torso, the head, that is considered dangerous until proven otherwise, and especially any extremities proximal to the elbow or the knee. Why? Because okay, one is obviously major vessels can be involved. The second thing is that anything from here can also go into the chest as well, and anything through the proximal tie it can go into the abdomen as well. So you cannot actually predict the trajectory from the external wounds most of the time. So that is why again you have to assume the worst in these kinds of patients. Gunshot wound, obviously they are going to be dangerous, and crush injuries are also going to be dangerous mechanisms. So all of these things are going to be triaged red most of the time, depending on, it also depends on what kind of scenario you're working with. So if you're having 300 400 patients coming in per day, then perhaps your criteria is going to be modified somewhat, but most of the time this is going to be what counts as a dangerous mechanism and what's going to be your criteria for triaging as a red. So what I wanted to share here is that The definition of dangerous mechanism is going to vary depending on what guideline you're studying. For example, in the Canadian C-spine rule, there are some discrepancies. You have fall more than 1 meter or 5 J is given as dangerous mechanism. So the MVC speed more than 100 kilometers per hour is considered a dangerous mechanism. So this I find is more useful because more than 32 kilometers per hour, I would really start to be worried about multiple injuries if the patient was really going into insane speed like more than 100 kilometers per hour. So taking the history, so if you are taking history from some pre-hospital stuff, so there are some certain things that you have to ask for. So that is generally given as a missed injury. That is MIST. M for the mechanism of injury, I for the injury sustained, S for the symptoms and the signs of injury, and T is for any treatment that is given pre-hospital. Mainly in India, we're not going to have much of pre-hospital care. Most of it is going to be care given in another hospital rather than care given in an ambulance. Coming to primary survey, initially we go with airway and C-spine immobilization. So any polytrauma patient, we're going to assume that they have a C-spine injury until proven otherwise. So it is very important that they are going to have their C-spine immobilized immediately. Breathing and ventilation. So it is important here to remember that it's not just respiratory rate and SpO2. You have to look at other things like tracheal deviation, chest compression test, and air entry on auscultation. So you're doing complete inspection, palpation, and auscultation. So it's not just your vital signs. It's not just respiratory rate and SpO2. You have to or the rest of the examination of the chest is also counted in your primary survey itself, not secondary survey. Circulation and hemorrhage control, very important. Pulse rate, BP, capillary refill time, any obvious external bleeding. So you'll have to deal with that very quickly. Pelvic compression test and EFAS, all of this comes into your circulation and hemorrhage control part. Disability, you have Glasgow coma scale, pupils, and your RBS, and look for any gross focal neurological deficits. The complete neurological exam will be done in your secondary survey, but any gross deficit, like a patient is not moving their lower limbs, or they're not moving one half of the body, those kind of gross deficits you can make out in the primary survey itself. So you have to look for any of that. And exposure and environment, you have to do a complete exposure of the patient to make sure that you are not missing any injuries, especially any missing any occult sites of bleeding. And you have to make sure that the patient is not going to go into hypothermia after you expose the patient. So you have to make sure the patient has some warm blankets and all. Adjuncts to primary survey, chest X-ray, pelvic X-ray. So it's a good idea if you are having an emergency department, you have to have the facility to get X-rays done quickly, because chest X-ray, pelvic X-ray will give you a great idea about some life-threatening injuries in trauma patients. EFAS again very important to do in any kind of polytrauma patient, because that can influence management, especially if the patient is unstable. Venous blood gas, specifically what you're looking for is the base excess level and your lactate levels, as well as your other things. But these are the most important things that you like to look for in the VBG. And in some of VBGs, you can also get a hemoglobin level, which will give you a good idea of how much the patient is actually bled out by that point. And other things are also mentioned for adjunct. Secondary survey, you have the ample history. Ample history, you have things like allergies, medications, past medical or surgical history, last meal, and events leading up to the accident. So these are the things that you take in the secondary survey mostly, and you do a complete head-to-toe examination in the secondary survey. So we're not going into each and every part of the secondary survey, because that will take a long time, because you have different things for different parts of the body. For example, how do you examine the eye? How do you examine the maxillofacial area? So we're not going into that much in this particular lecture, because we are mainly going to focus on some practical things on what people can get into trouble with when you're discussing trauma scenarios. So, you have a first case here. So you have a 25-year-old male who is involved in a motor vehicle crash, a two-wheeler helmeted rider versus the divider. So And you do a primary survey obviously initially. Airway is threatened, and airway is threatened mainly because of poor GCs. You don't notice any particular blood in this or secretions in the airway as such, but ECS is on the lower side, but so you consider it threatened. So respiratory rate is on the higher side. SpO2 is maintaining 90% with oxygen by NRBM. So any polytrauma patient, you do start the patient on oxygen by non-rebreather immediately. Left side chest compression test positive. Left side air entry is decreased. So some of you might be thinking about doing percussion. Percussion in BC emergency department, which are very loud, is not really going to help you a lot. So it's much more productive to actually look for a pneumoscan, and you can see one done in this patient here, and you can see a lung point. You can see that on the left side of the screen, you can see the pleura moving, and the right side you are actually not seeing any movement. So here visualizing a clear lung point here, and this is pathognomonic of pneumothorax. So this can only be pneumothorax. So there is not one diagnostic dilemma here compared to medical cases where you have patients who have chronic lung diseases and you're not sure whether this is bulla or diseased lung and all. So most patients who have trauma who are otherwise healthy. So if they have absent lung sliding on one side, that is generally going to be due to pneumothorax. But it is practically speaking, it's always a good idea to do it with a linear probe when you're looking for lung sliding, and you make sure that you have good check of all of these zones before you actually comment the patient as having pneumoscan negative. Especially make sure to have a good look at zone 1, because that is generally the place where you'll find your lung points. So pneumoscan is positive. Other than that, you can see the patient is tachycardic, BP is on the lower side, pulse pressure also little bit decreased. PCT is positive, fast is negative though. GCS is on the lower side, E2, V2, M4, people's contracted, RBS normal. So the question here is, we have multiple problems here. So generally in trauma cases, even though when we are describing it in exams and all, you'll go one after the other. It's like airway, breathing, circulation, etc. Generally, when we have a full team for trauma, all of these things will be addressed mostly simultaneously. So the question is, which thing would you want to address first of all in this patient? Arushi?
So the GCS is low. First, I would like to go ahead with intubating the patient and low IV cannula I'll start fluids for this patient and simultaneously
Okay. So,
like should we order blood also for this patient simultaneously? That I'm not sure.
yeah, so we'll come to that. So basically, so this was the blood gas so of the patient. Again, imaginary case. So this is basically made up these cases, but I've used images from real patients that I've seen. So again, this is very bad. So base excess is minus 17. So minus 17 more than minus 10 is generally considered as grade 4 hemorrhagic shock until proven otherwise. Hemoglobin you
Okay.
see is 5, and pH is also not very good, 6.97. So what happened in this imaginary case is somebody decided to go for a chest tube immediately, and they found that there was gush of air and drained about 200 ml of blood, and then they decided to intubate, and because of the poor Jesus and all, shortly after intubation, patient went into cardiac arrest. And the reason why the patient went into cardiac arrest is this is what the patient's pelvis was looking like. This is an open book pelvis.
Open book practice.
So what happens is that if with an open book pelvis, if you give paralytic to this patient, so paralytics will cause massive amount of bleeding into the pelvis if the patient is not binded before you intubate. So
Oh,
patient completely can bleed out very fast, and that is why the patient coded. So this is a difficult case. This is not an easy case because you have multiple problems going on at the same time. But this is what happens in polytrauma sometimes. You have patients can have multiple life-threatening injuries at the same time, head, thorax, pelvis, all at the same time. So the thing is that in trauma, generally, if the patient with trauma is coming with shock, it is hemorrhagic until proven otherwise. Yes, we commonly do see other types of shock like obstructive shock, like
Neurogenic shock.
neurogenic shock, but always we like to assume it is hemorrhagic until proven otherwise. So we will generally have to activate MTP when you see something like this. And if you find out that it's not hemorrhagic shock, you can always deactivate MTP later. But you have to resuscitate the patients first before you start intubating, because anyway the patient is sick, the hemoglobin is 5, already bled out quite a bit. So intubation can be dicey. A patient needs intubation, but there is less chances of patient going to into cardiac arrest if you resuscitate with blood products and at least you give some blood products, then you intubate, then you have a better chance of not actually arresting the patient. So that is the important thing about this case. So always assume shock in trauma to be a hemorrhagic until proven otherwise, and you have to resuscitate with blood products. So IV fluids, even though in ATLS they do say like you can start with 1 liter of IV fluid initially before moving to blood products. Earlier it was 2 liters, they changed it to 1 liter because basically the problem here is bleeding, and bleeding is not going to be solved by IV fluids. Bleeding has to be solved by source control and blood products basically. And the newer version of ATLS is basically the whole ABC is going to change. They're going to bring it into XABC, X for any exsanguinating sources of bleeding. So you have to treat that first and foremost before you go on to anything else. So the whole concept of trauma is, the approach to trauma is changing a little bit. But again, the emphasis here is to, assume shock and trauma is hemorrhagic shock until proven otherwise. Even if you have other things like pneumothorax also at play. Second case, 37-year-old male patient, motor vehicle crash, three-wheeler driver roll of the vehicle. Again, airways threatened. GCS is poor, even V1 M4, pupils constricted. Otherwise, breathing part, circulation part, nothing immediately life-threatening sticks out to you. So you intubate the patient with fentanyl, etomidate, and rocuronium. Then you send the patient for CT. CT reveals right-sided FTP SDH with 4 mm midline shift to the left. So there's a problem here. And the problem here is the patient has been given rocuronium. The problem with the rocuronium is that patient will be paralyzed for the next 45 minutes. And the neurosurgeon will not be able to actually assess the GCS before that, which can cause unnecessarily delays in your ED. So, in general, in trauma, if you're going to choose between either of the succinylcholine or rocuronium, generally it is preferred to go with succinylcholine. It's not a hard and fast rule, but especially if you're considering a severe head injury, it's always a better idea to intubate with succinylcholine because it will wear off within 5 to 10 minutes, and then the neurosurgeon can do their GCS and whatever examination they want to do afterwards. It's a very soft recommendation. It's not a very hard recommendation, but it is there. Only thing you have to do is always make sure that you don't have any contraindication for succinylcholine, like anything that can lead to hyperkalemia, like renal failure, like any crush injury, like any severe burns. So you have to keep those things in mind before you start, using succinyl, obviously. But it in general, it's a good idea to prefer succinylcholine compared versus rocuronium in the trauma setting. Coming to case number 3, 28-year-old male patient, unknown, found roadside by police. So there is no history. You have no history. Nobody has much of a clue about what happened. Airway is threatened, and the patient is intubated. And basically, you are taking over. Imagine you're taking over for this patient after some time and just reviewing the history and seeing what happened. Patient was intubated. Breathing circulation part was fine. Pupils were constricted, RBS was normal, and secondary survey is significant for these injuries. So these kind of look like self-inflicted some abrasions here on the patient's body. Imaging was done. Imaging showed nothing special, no real acute trauma-related findings. GCS improved, and then the patient got extubated. But after the patient gets extubated, you get another call from the nursing staff saying that the patient is not really breathing properly. So you go and see the patient, and you see that patient is having a respiratory rate of 6. Pupils are contracted. Patient is kind of altered, drowsy, and patient is having some type 2 respiratory failure here. Respiratory acidosis is there. So this toxidrome is kind of looking like basically opioid. So this was actually opioid overdose. So this can happen. So or even though the number one rule in trauma is that anything that happens to the in a patient with trauma is assumed to be due to trauma until proven otherwise. Always there are some exceptions, and it's not always the case. But our mentality should always be that anything that happens to the trauma patient is due to trauma until proven otherwise. But the one thing caveat that comes with that is that toxicological causes of altered sensorium is quite common in trauma patient because a lot of the time the motor vehicle accidents they happen after people get intoxicated and all those things. So sometimes they can coexist. Sometimes you can have positive things coming on the urine tox, even though uh, that isn't actually relevant to the actual acute presentation. For example, patient might be chronically taking cocaine or something, but patient's current problem is the patient is having an acute STH, and that is why the patient is actually altered. So the reverse is also true. But if your trauma workup is completely negative, that is when you start looking for toxidromes. So if you have something like this where it's clearly fitting with a opioid overdose picture and you rule out trauma, then you start treating it as opioid overdose basically. So this can happen. So you have to keep this in mind as well. So the problem is that once people work in a trauma center, because we have a full-time trauma center and you only deal with trauma patients there. So if you're working there for a few months, you people tend to actually forget about medical causes of alternate sensorium. So you have to keep those things in mind as well. Case number 4, 27-year-old male, two-wheeler skid and fall. So he is having primary survey, airway is fine. See, breathing part is also fine. Circulation is fine. GCS is kind of drowsy, E3, V4, but he's also fine. Not something, gravely abnormal here. So, only thing that is notable here is that on the secondary survey, he's having some bleeding in the mouth and nose, but nothing active. And what you notice is that patient is having some difficulty lying supine. So primary survey is mostly normal, except for matlab, slightly decreased sensorium. Otherwise, it's almost completely normal. And some maxillofacial bleeding is there. And patient is having some difficulty lying supine. So the question is, does anybody want to intubate this patient or not? I'll leave it to you. You can type it out. Intubation, yes or no. You can type it out in the chat box, or you can unmute yourself and speak also. Do you think this patient should get intubated?
Sir, I didn't know primary survey, there was a network issue. Can I know
Eh,
primary survey?
This thing. So, does anybody want to intubate this guy?
But so the patient GCS is also fine.
Yeah. This is a
Um,
13 is, that's not really
uh,
something that you'll
it
panic
is-
about.
uh, will not intubate.
Okay. I think most people would agree with that. Most people would not intubate this patient. But this is based on a real story, actually. And what happened was that patient went to the CT room. Patient had a seizure in the CT room, aspirated. He was rushed back to the ED. He was in a peri-arrest state, bradycardic, shallow respirations. Luckily, we were able to intubate him successfully without patient arresting. Although he almost did it, he was like almost seconds from arresting, but so, somehow that was prevented. And eventually, patient had a happy ending. He eventually got discharged. Eventually, after a few days. But that that is a very important lesson in this thing. Even if you don't have hard indication for intubation, or there are a couple things you have to be worried about. One thing is that if you are wanting to do a CT scan on someone and patient is not able to lie supine, that is very dangerous. So especially in trauma patient, the problem is that one thing they're having head injury, even and head injuries are very often they are associated with some kind of maxillofacial bleeding. The problem is that once the patient become drowsy, they they will easily aspirate the blood, and that aspiration is also what can lead to patients actually going into cardiac arrest. So that is a dangerous combination that you have to be worried about in head injury patients. So even though everyone is right, there's absolutely no indication to actually intubate this patient, but still the only red flag here was that he was not able to lie supine. So I'm not saying that the patient needed an intubation, because sometimes these bad things will happen. You cannot intubate every patient with a GC, this kind of presentation. That's not practical either. But remember that in trauma patients, the threshold for intubation is much less than it would be, for example, for a patient with hepatic encephalopathy. Because those patients, even though their GCS is low, unless somebody actually tries to feed them something through their mouth, they are very unlikely to actually aspirate. But in trauma patients with bleeding, they're bleeding in the nose and mouth. It doesn't take a lot for patient to suddenly aspirate. That is why in our center we generally have a very low threshold for intubation. According to East guideline, these are the level one recommendations for intubation: airway obstruction, hyperventilation, persistent hypoxemia, GCS less than 8, hemorrhagic shock, cardiac arrest, and in smoke inhalation with any of these things, those are also hard indication for intubation. So there are some level 3 recommendations as well for intubation. You can go through these later. But basically, our patient doesn't really qualify for any of these indications. But the problem is that he still almost had a very bad outcome despite that. So we have to remember that we cannot send any unstable patient to to the CT scan. So especially if the patient is not able to lie supine, and in trauma cases, you have to do a pan CT. So you're getting CT head, the C spine, and thorax and abdomen as well. So that takes a bit of time. So patient will be required to lay supine for like 15 to 20 minutes probably. So that can be dangerous. That is why you have to be very careful while you are actually sedating these patients and sending them for CT, because there is a very fine line between getting away with not intubating the patient and the patient aspirating as soon as you sedate them. So it is very tricky process, and something that we don't actually see much in medical patients. So you have to have a lower threshold for intubating trauma patient. In our center, that is why we keep a threshold of 10 actually. That is our center. I'm not saying that we should practice that in all centers, but we generally here, based on our setup, we have a little bit lower threshold for in intubating trauma patients. And always be careful about sending patients who are unable to lie supine for CT. So last case, 23-year-old male came with history of fall from 13 feet. Primary survey normal, secondary survey is normal. Just a few abrasions over the face. Question is, do you want to discharge the patient?
13 feet. No, sir. Fall from 13 feet. I think.
So what do you want to do?
Almost twice the height. Dangerous
Significant height.
mechanism of injury.
Dangerous mechanism. I would like to observe this patient.
Yeah, you can observe or you can image the patient. As we talked about, as per the
Fall from greater
criteria,
than 20 feet है वैसे तो, but
we have to
13.
remember that these are guidelines for mm, Americans basically, and they generally tend to be taller than the average Indian. So those guidelines cannot be directly applicable to the average in Indian. So generally, we have to keep those things as well in mind. So generally speaking, anything more than 10 feet, once you go about 10 feet, you can have a lot of occult injuries that are not easily apparent on examination, clinical examination, I mean. So it's always a good idea to have a low threshold for imaging in these patients. And once you start doing CT scans, you'll find that a lot of these patients actually end up having multiple injuries, and you'll miss a lot of these injuries if you don't actually scan them. So this patient actually ended up having multiple fractures of the C spine, even though the patient was didn't have any neurological deficits per se. So again, this patient, whether to take in red area or not, that's another question, other debate. But imaging wise, imaging is definitely needed for this kind of patient. So you cannot send the patient home without some kind of imaging with this kind of history. That is why you always have to, uh, you know, you always have to acknowledge how the dangerous mechanism. So whenever you have a dangerous mechanism, some sort of imaging is required. So, especially for CT head and C spine, I generally have a very low threshold for imaging. Scanning the thorax and abdomen, that's another story. Then that is another debate that I don't want to get into. But generally, all of the guidelines you have for imaging the head and the C spine, all of them will say that if you have a dangerous mechanism of injury, you have to image. So, regardless of anything else, if you have a dangerous mechanism of injury, you have to image. Second thing, if the patient is intoxicated, you have to image. If the patient is having ultrasensorium, you have to image. So, those things are common for all kinds of guidelines for head, C spine, etc. So, if you have dangerous mechanism, you have to keep those things in mind before sending the patient home. So imaging can be CT scan. Sometimes some people like to do X-rays as well. So X-rays are going to be much more difficult to read, to be honest, because there's going to be a lot of overlap of the bones. So sometimes the fractures might be missed. You might not miss very obvious deformity of the C spine, but you won't pick up as many injuries as you would with a CT of the C spine. Another thing is, generally in patients who have an indication for getting a CT of the head, they will also have an indication for getting a CT of the C spine. So both of the injuries tend to coexist because head and C spine are just very close to each other. So they say almost around 25% of severe head injuries will have some injuries of the C spine as well. So anybody who has an indication for a CT scan of the head generally has a indication for a CT scan of the C spine as well. So don't try to image only the C spine or only the head. So generally, it's a good idea to get both of them done together. Thorax abdomen is another story, of course. So that is the whole pearl about this particular case. So always have a low threshold to do imaging in patients presenting with a dangerous mechanism of injury. And dangerous mechanism, sometimes it might not always fit the dangerous mechanism given in the textbooks also. So So take home for points is always have a systematic approach to trauma patients. So primary, secondary survey, you have to learn how to do that. And those are things that you learn on the floor basically. So it's not something that I can teach you perfectly in the lecture here. So you'll learn it by seeing more and more trauma patients. And any shock in a trauma patient is going to be assumed to be due to hemorrhage until proven otherwise. And any symptoms in a trauma patient is again assumed to be due to trauma until proven other. For example, patient is having chest pain following trauma. We assume that is going to be due to trauma until proven otherwise. If there is no fracture, the first thing you should be thinking of is blunt cardiac trauma, not MI. So that is a difference between the approach. So it could be MI. I'm not saying it couldn't be, but what we are thinking of, our thought process is always going to be initially think about the trauma-related causes of the patient symptoms. So that was basically what I wanted to share here today. So thank you so much for joining.